Hello everyone, this is Bob Brown with Community Coronavirus Update number 94. We'll talk about juggling good policy with sound science and key questions for the coming weeks. So here local in Lincoln, looked like our numbers were dropping a bit. They don't seem to be maybe dropping here this past week. The question is what's going on here? Is there some funkiness with the data, or are things really going back up again? I think the true answer is we actually don't know yet. If you look at some of the case reports, there was a warning on today's situation report saying there was a delay in testing, so 43 cases were reported late, plus the turnaround tests are hitting 6 and 7 days, which makes our data really hard to trust. Combine that with our weekly positivity rate being really high, I don't think you can really say whether our cases are going down versus up right at the moment. Usually that our public schools numbers in Lincoln Public Schools are dropping, but I don't know about the whole community as a whole, and certainly not the surrounding areas. I think this New York Times, where they use a combination of both community spread and test positivity rate, might be a better way to look at things right now, and that this would make things kind of tentatively worried about in Nebraska about what direction things are headed. But moving to the theme, and that ties into this, how good is your data? So, there's a really good, I think, policy discussion on public health on Paula's podcast. I'd encourage you to take a listen to it. It talks about how policy is more than just following the science. It'd be nice if we could just follow the science, but there are things that science can't answer, or we just don't have questions yet, or the answers may change over time based on new data. But also some things are just a value decision, and science can't always weigh in on those types of decisions. And so I thought it was a very good discussion about really what happens behind the scenes and how you have to make some of these trade-offs. This was a discussion I presented to the school board Tuesday night, is that, why are we doing all this and how long should we keep doing it? Well, there's a couple real strong reasons why. And one, I think, as a school system, we have a duty to create a safe, common environment for one, LPS students, but also their families, because whatever kids capture in the school, they'll bring home to mom and dad and grandma and grandpa. Also for our staff, they also we have to make sure that it's safe for the families as well. And then of course the entire community, because 1/3 of the community is directly tied to the school system. So it's important that the school system be a safe environment. And then also look at the balance. What are we achieving by having the safer environment? One is that we're saving lives. And so if you look at the data on mortality in Lincoln, Lancaster County versus Omaha, Douglas County versus Iowa and South Dakota, you'll see a very big difference in mortality rate. I can't give you Nebraska data because Nebraska doesn't report as a state in the same metric anymore, so I just have to use this as the best I can at this point. But this is a significant number of the lives saved. If we look at Lincoln versus if we'd have performed like Omaha, Iowa, or South Dakota, that's a difference of anywhere between 150 to 500 lives. And so doing what we did has helped. Was it worth doing everything we've done over the last year and a half to save 150 to 500 of our fellow citizens? Well, that's a value decision. It's not a science decision. And so that is a decision that policymakers have to make. And I think in Lincoln, we've made the right decisions, even though we've gotten a lot of flack for them. But that's part of the give and take between public policy, public health, and science, is that they're not as simple and black and white as everybody wants them to be. Still, there's still some leftovers from that Great Barrington Declaration from a year ago, and not all of the Great Barrington Declaration was wrong. There are some good insights, but there are also, unfortunately, a lot of key assumptions that were just flat wrong. That is why I don't agree with the Great Barrington Declaration. But there's still a few diehards out there who still believe in it and haven't changed their minds in a year, despite all the new data. I think the Great Barrington had a key insight. One is that there needs to be a balance between saving lives for COVID and the health and economic cost of public health measures to control COVID. And that's actually what that John Suplin's Public Health on Call podcast is about. Yes, there is a trade-off there, and that's something that is hard to make that trade-off, and we need to quantify that as best we can, but we may not have that. But you also have to realize what your assumptions are, and sometimes if your assumptions have key flaws, you need to adjust it, and that's what I think the biggest problem with the Great Barrington. They made a couple big mistakes. One is they assumed that COVID was one and done, like measles, and some thought maybe it would, and a lot of us hoped it would be, but it's not. It's not one and done. You can get infected again, and we're seeing the data on that. It assumed that we could isolate and protect the vulnerable for a prolonged period, and it turns out we can't. And a lot of us who actually work in the community know that wasn't going to fly in the first place, and so that was a flawed assumption. The other thing is it did not account for masking, and that, for example, universal masking in schools would make it so that lockdowns weren't necessary. And so some of the big economic costs were because of the lockdowns, which turned out we didn't have to do lockdowns, that if you actually did effective masking, you wouldn't have to do those. And so that changed the equation quite a bit. And it also assumed that we wouldn't have a vaccine in less than a year, which we did. And so the economic costs were much lower if you include the effective masking and the fact that now we have effective vaccines. And so all those things made the Great Barrington Declaration wrong, unfortunately. Certainly it was a worthwhile theory considering, but it was wrong. And this is something I did way back, if you go all the way back to episode number 17, I talked about the cost benefit analysis. Is it worth it to do these things? The problem is our projections were so widely all over the map because it all depended on your assumptions. And I actually did a whole cost effective analysis of that in that episode. And the cost per quality of life year saved was anywhere from $9,000 to 2.1 million, depending on all these different assumptions, which we just didn't have a really tight data on. Now we have a better way to look at things. And I think, frankly, some of the things would have been economically better had we controlled coronavirus better. So again, I think it's worth listening to this podcast because I think it frames it in a very good way. Another example is the discussion about kids. Children are at low risk for COVID, but they're not at no risk for COVID. People keep missing that, and COVID risk is higher than influenza risk. Now, we didn't know that a year ago. And if you go back far enough in these podcasts and even my school board the videos, you'll notice that there were times early on where I said that coronavirus was not as bad as for any worse for kids than influenza, because the initial data, that's what it looked like. And the black line here is the fatalities of coronavirus for children. All these other lines are the last 10 years of flu pandemics or flu epidemics every season, starting for a whole 19 month time frame. So you have one season plus another season because this has crossed 2 years. But you'll see a year into it that the coronavirus fatalities were already worse for children than than any of the flu epidemics the past 10 years. And the other thing you have to keep in mind is that when we were in pretty much lockdown this first 3 months, there wasn't much spreading around in kids. And then we had masks in schools all through here. And even there, it started showing that actually no, coronavirus was causing a higher mortality rate than influenza. So yes, there are some value decisions to be made, but you can't make a good value decision politically if you're just lying about the data. The data is really solid now that coronavirus is worse than for children. However, is it still worth it though? So for example, we're talking about 200 to 300 lives. Well, what's the economic value of 200 to 300 lives of children? That's really hard to put a price on. And so how do you decide? That's just not an easy decision. Science can't answer that decision. That's a political decision. But although you can't simply follow the science, you have to at least be informed by the science and use good data. And that's my biggest frustration, is people just flat out lying about the data. So, and then there's not just deaths for children. There are still acute hospitalizations where you get 3 to 6 at children's right now every week. There's the multi-system inflammatory syndrome, which can be quite a problem for kids. There's the myocarditis, the long COVID, plus the missed days of school for the kids when they're sick with COVID and the parents that have to take home. Compared to the minimal challenge of mask versus the trauma of losing a parent. So yes, wearing a mask is a pain. I don't like wearing one either. And yes, it can cause some trouble with communications. However, what is the cost of that versus the trauma of losing a parent or a grandparent? And we've now quantified that. So last week, the Journal of Pediatrics looked at the number of basically the COVID-associated orphanhood, meaning about 140,000 U.S. children lost a primary caregiver, either a parent or a grandparent for a multi-generational household, or sometimes the grandparent is the guardian. 140,000 kids lost guardians. And from a disparity standpoint, it was much higher in minorities. And so there's a cost that also needs to be quantified that some people just aren't looking at. So, and then the other thing right now is we need to control spread because, Lincoln, the good news is for a while our hospitalizations in Lincoln were dropping, which is important because we have to take care of people from all the other communities that aren't doing the same public health things that we're doing. Unfortunately, what we've seen here in the last few days is an uptick in hospitalizations here in Lincoln. I don't know if this is just a short blip or there's something happened. Well, one thing that happened is these rates went up kind of right after the Garth Brooks concert. Is this the effect of the fully packed Husker games? I don't know. Maybe it is, maybe it isn't. I think it's going to take a week or two to see how this data shakes out, partly just because our testing is so bad right now and the turnaround is so slow. We really don't know where we're at, and so we're still, hospitalizations I think are still too high, and so I don't know if I trust this data here. Also, if you go down the road in Omaha, they're still having just as many hospitalizations. In the total hospital capacities, they're having more of a problem because all the stuff they've been trying to delay is also coming in. People with bone marrow transplants and cancer operations and heart attacks can't wait. We need to slow this down and have fewer coronavirus hospitalizations so that we can free up some capacity in our hospitals for all the other stuff that needs to get done, which is yet another problem. So, at the end of the school board, my president's school board, I said, is it worth the effort to do all this to delay spread? And I think it is. It's worth this effort because, one, we've got a couple of unanswered questions. There's a lot of high-risk families that they might need to get boosters. We have a high-risk LPS staff. They may need to get boosters. And there's a chance that we may have a vaccine for 5 to 11-year-olds so they don't have to go through coronavirus and take the risk of that hospitalization. And yes, there's a chance of death, though very small. There is still a chance. We need to give those families the choice to get vaccinated or not, and that's going to take through November, December. So I think we're going to have masks in school, at least here in Lincoln, through November and December for the most part. Uh, to me, I still think our biggest policy failure in Nebraska right now is a lack of vaccine verification for things like events like concerts and games, restaurants and bars and travel. We do know that restaurants, bars, concerts, that's where the coronavirus has spread more than anything else. Travel is mostly taken care of because we have masks required on planes, for example, and more travel restrictions are requiring pre-testing and vaccination. I think if we did all this, we wouldn't need vaccine mandates, but it's the lack of doing this that's creating the need to have some vaccine mandates. So I don't like to mandate anything either. But if you're not going to do this stuff, you may be left with this if this is, our only solution left to go. It's frustrating to me because the UNL has been using a Safer Community app and doing exactly this type of thing since January. I don't know why you aren't rolling this out for things like Husker games and other stuff. It reminds me of the old tobacco ban where people were some were mad because we banned cigarettes in restaurants, but a lot of us didn't like sitting in cigarette smoke in restaurants, and I don't like sitting in a restaurant knowing I might be exposed to coronavirus, even though I'm vaccinated. There's more than likely I wouldn't get it, but still the risk isn't zero. I'd rather not have to deal with that risk. I would rather go to a restaurant that did require vaccination, honestly. And if we had that, I don't think we need the vaccine mandate. Then lastly, we have some key questions for the coming week. So again, one reason to kind of keep things from spreading is we're going to get a lot of answers to a lot of things, and there's still some things we don't know. I think Caitlin Gidelina and your local epidemiologist does another good job. She just reported this report about mixing vaccines. And so thankfully, there's now some data on this that actually shows that, yes, we can mix the vaccine. And for those who've had Johnson & Johnson, they may do best getting a Moderna booster, for example. So this data is all being discussed right in the next few days and next week. And so hopefully we'll get some recommendations out here. So I think we need to keep down spread so that those who might benefit from that booster can make a good decision. And then before we start opening things up from a non-masking standpoint. She kind of goes through a couple of things that there's some key things tomorrow, actually this is today, that they'll be talking about the Moderna booster. Friday they'll be talking about J&J, and then the effectiveness of mixing vaccines, and then there'll probably be a CDC opinion on some of that maybe by next week, and then on the 26th they're going to look at the vaccine efficacy for 5 to 11-year-olds. So all this is on tap. So this leaves some big questions, I think, in schools in the coming weeks, at least to the ones that are doing the right thing and masking their kids. How long do we extend masking in schools? We'll find out. I think we'll see what the data shows in the coming weeks. Do we have some differential masking based on vaccination status? And I actually, personally, I'm in favor of this. We've been doing this in healthcare for years for flu shots. And if somebody didn't want to get a flu shot, say a nurse, she say, fine, you don't have to get a flu shot because we don't want to mandate it, but you got to wear a mask the entire flu season. And so I'm in favor of doing that. Do we have some differential masking based on grade level? Because the 7 to 12-year-olds, they've had the opportunity to get vaccinated, but the K through 6 haven't yet. Although with the new Pfizer, we might be able to give them the opportunity. Do we put in some surveillance testing? And the biggest worry of all for a lot of us is, will there be a new variant this spring? That's probably our biggest question we have remaining out there. I think we have two potential scenarios going forward. One is that we could get some degree of combined community herd immunity with greater than 85% of people immunity that lasts, with a combination of first fully vaccinated people who got immune the easy way, or the repeatedly infected people who got immune the hard way, some of whom died and had complications they didn't have to have, but one way or the other we might get there. So we could get to the point where this sort of quote herd immunity with more than 85%, we could hit that by December, January, and maybe we would be done with this. That would be great. Unfortunately, though, we don't know that that's the case. We don't know that there isn't a new variant that will escape this immunity, and we'd have another surge next spring, and that's the other really big question. And again, Caitlin Gidelina a few days ago did do some analysis about that. The one people are worried about is this mu variant, which does seem to be less or more likely to escape immunity somewhat. However, where it's coming from, mostly in South America, it's getting outcompeted by Delta, and so it's kind of interesting. There's some interesting dynamics here. Well, Delta is suppressing the spread of this because Delta is more infectious. However, when this immunity, if their immunity to Delta is to Delta but not to mu, you could see this coming back. And this is something where we really need to be following all the other countries around us and doing better job of sequencing here in the United States. So if this does happen, we're prepared this time, and we don't wait till hospitals are overloaded before we do anything again. You think we'd learn, but boy, we just aren't learning that one the hard way. So hopefully this discussion is helpful. As usual, all those links are in the bottom in the notes section, and I encourage you to go look at those links yourself. Just so you know, this is what I do for a living, so you know that I am gainfully employed, and I do have some experience in leadership positions. You can verify who I am. Past episodes are on that healthylincoln.org if you want to go there. And for those who ask, this is actually going to be my last update for the month. I'll be back in early the first week of November. I've got busy at work and or vacation, and so I'm not going to be doing another episode till the first week of November. So don't email and ask, because it won't be then until then.